Good morning or afternoon, depending on where you are. This is Sharon Terry from Genetic Alliance, and welcome to our webinar series that we've entitled Overall Reg for All, Registries for All. Today, our webinar is on registries and biobanks, essentially the basics, nuts and bolts. I did notice when I looked over the list of individuals who have signed up for the webinar that in fact some of you are more expert than I am on registries and biobanks, and this webinar we intend to be very, very basic to really give a primer to people who don't have any familiarity with registries or biobanks, and especially disease groups that are considering in fact making those an effort in that regard. So if this is the wrong webinar for you, I will not be insulted if you hang up or go away. If you still want to participate, listen, etc., please do so and welcome. We have a number of people registered, more than 60, and so we are not going to be opening the lines for questions. We do have one webinar for disease advocacy groups in a couple of weeks that is where we will have the lines open and have actual dialogue about registries and biobanks. But for this one, I will be presenting, and then we will be taking questions. So we're going to ask you to write your questions in the box on the GoToWebinar software and the little dashboard there. If you have an idea about what you'd like to see this webinar cover, you should feel free to write that now in that box. I can't guarantee that we will cover it, but at least it gives us some fodder for the kinds of things we should be covering in upcoming webinars. And again, as we go through the webinar, if you have any questions at all at any time, simply put them in the box. I'll try to answer some of those on the fly, but we'll certainly get to them at the end of the presentation, which I hope will take us only maybe half an hour or less, and then we'll have a half an hour or so for questions. All right, so without further ado, registries and biobanks. And let's see if I can get my, there we go. Okay, today I'm going to actually use two resources a great deal during this conversation. These resources are both really stellar ones for registries, and then in the second half of the presentation for biobanks. And the first one is this essentially book, user's guide, called Registries for Evaluating Patient Outcomes. And the authors, editors of this book are actually in their second edition. And it really has become the Bible in many ways. It's put out by the Agency for Healthcare Research and Quality, AHRQ, and we certainly have used it a great deal in our work. I will also be giving you some snippets of our experience as I move through this. As I think most of you know, I am a complete lay person. I don't have any credentials in terms of science or academia in this regard. And my work really has been from a kind of citizen science perspective of having built my own registry and biobank for a disease my children have beginning in 1995. It was the first lay-owned registry and biobank, and then building a platform for other diseases to do the same, also all lay-owned and managed. However, we, from the start, wanted to make sure that we were using quality resources. This resource didn't exist when we started, but there certainly were bits and pieces of things that were helpful. And I'll comment on some of those as I go through, but certainly give this resource a look, and I have a URL at the end for you to click through to get to. Okay, so registries. A lot has been said about them. There are many, many ways to discuss what they are, what they do, how they function. The terms used interchangeably for the software itself and also for the actual act of creating one. And so this next couple slides just list some ways in which registries are actually characterized. And so, for example, and again, a lot of this I'm pulling from the AHRQ guide, geographically based population ones, public health ones like for vaccines, outcome registries that might look at interventions and how well they are working or not, adverse events, product registries, prevention registries, and then certainly disease-specific registries, which is where we'll focus a little more today, that allow simple listings, cohort building, natural history studies, epidemiological studies, and so on. More registries, where do they live? Hospital-based registries might include how do we improve patient care, how do we take care of professional education, just simple administrative information and administrative accounting, and then certainly clinical research more and more becomes part of what hospitals and health systems are looking at. Population-based registries might look at cancer prevention, again back to either geographic or non-geographic cancer-specific, organ-specific kinds of determinations, early detection, determinations of rates and trends, patterns of care and outcomes, research and evaluation of control efforts. And we're seeing lots and lots of outcome registries be born, largely because of the attention being given to this area by organizations such as PCORI, and in fact recent RFPs from them looking at more and more what kinds of tools do we need to do this kind of evaluation and outcomes kinds of studies that make a difference for people in a real way and not just for retooling the way a hospital does care or maybe even accounts for the cost of care. For this discussion, we'll largely be talking again, although there's tons of blurring here, and the purists would not like me saying this, but I think some of these registries sort of merge into one another in a way, sometimes both in form and function. And for this conversation, we'll be trying to stay with disease registries that essentially create an organized system that allows us to ask specific and meaningful questions, although sometimes those are open-ended as well, and that standardizes the data in some way so that it's useful not only within its own system, but one hopes beyond the system. And again, another place we're seeing a lot of activity these days is in standards, in standardizing. I'm sitting on the HIT Standards Committee for the Office of the National Coordinator, and we're doing a great deal of work on how do we standardize information, not for registries in that instance, but certainly registries use lots of the systems that have already been established, whether it's for disease characterization or for billing or for laboratory reporting, so things like SNOMED CT and HL7 and ICD-9, 10 codes, those things do find their ways into registries to make those registries more interoperable and more useful, one hopes. And then as electronic medical records grow across the nation, one hopes vis-a-vis the High-Tech Act that we're going to see more and more ability to create registries, certainly by data that's already either standardized or beginning to be standardized. This is a nice slide that Richard Glicklich showed in a meeting many years ago, actually now. I was going to say just a couple of years ago, it feels like, that I thought was useful in terms of saying the idea that these registry types and the perspective of the registry overlap. So in this case, we have this big black rectangle that's the disease registry, but within that you may in fact find, and actually many of these circles could have been drawn both within and without the disease registry box, but overlapping in the sense that some of them are testing for one thing but certainly are part of another. So for example, you might have a clinical event registry that's looking at a single procedure, or it could be in fact looking at drugs. And so lots of overlap and lots of inability to actually distinguish those in a way that makes them pure hard boundaries. The handbook that I showed at the beginning, the essential Bible of registries, actually goes through a lot of wonderful steps, and again, I recommend this very much for people who are neophytes in this area, and even those of us who are experienced. I've referred to it many, many times, on essentially how to create a registry, how to operate one, and how to evaluate one. And I will talk a little bit about the first section of this, again, taking a great deal of this information from the actual guide, the user guide itself. And in planning, essentially you're going to want to look at what is the purpose of the registry. And again, people who are really expert in registries spend a lot of time with this particular question. It's very important that you understand the purpose of the registry, and that different registries are built for different things, and so not every registry can answer every question. Many of us who come from the disease community say, well, aside from characterizing the disease, we're not sure what the purpose of this registry is. And so I think we've had to look at ways to make that more flexible. and also to let the registry itself start to ask some of the questions that we might answer, and then to retool the registry, reformulate the registry, put a branch or an addition on the registry that will allow further questioning. That works okay in a disease community. It doesn't work great in other scenarios where perhaps the interactions are more constrained or they're limited by the ways that people come to it. So for example, a hospital and a certain procedure registry would not be able to then go off on another tangent and ask a different question. Even if that question started to emerge from the data, it would require probably a more cumbersome project. We hope that registries will become more flexible, and we've been working on some tools that would allow that, we hope. But again, I think we might start with one purpose, and I can give the example that my PXE International Registry, which is pseudoxanthoma elasticum, disease specific, started to characterize the condition. And as we soon found out various things, so for example, every woman who had ever had a mammogram with PXE also had a biopsy. That became a purpose for the registry in the sense that we wanted to answer why did that happen, and whether or not that was an attribute of the disease or there was just rampant cancer in this group. And so we were able to add on to the registry, ask some other questions, bring in some other medical records and images, those sorts of things, and do a double-blind randomized study of mammograms from a control group and from the PXE group, thus proving that it was part of the disease. But in any case, that was not the original purpose. We were able to kind of move into that purpose, but with a great deal of activity. So you want to also identify the stakeholders. Who is this registry for? Who's participating? Who's using it? That sort of thing. Governance is very, very important, and I think we're seeing some changes in governance over the last few years, and I'll talk a little bit about that later. Defining the scope of the registry, again, really important to the purpose. Defining the target population, and we'll talk a little there about bias, enormous bias in almost every population you can put together except for very well-contained ones. Assess feasibility, and then securing funding, of course. So in designing the registry, you're going to really want to look at what's its major purpose and whether you're doing hypothesis testing or generating. And I think even when the guide was written and in other meetings and conversations I've been in, there's certainly been way more focused on hypothesis testing. And again, I think people who are experts in registry design vastly prefer that the registry be designed to test the hypothesis. It is probably the primary reason that registries are created. However, I do believe there's a surge in hypothesis-generating registries, and even things like patients like me, and certainly our own Registries for All, are starting to understand how do we ask for registries to actually ask the questions as well as answer them. Choosing a study design is important, and there's certainly a lot of scholarship in that regard. Selecting the right data sources, populations, and comparison groups. Controls are sometimes very important, and that they are sometimes easier and sometimes harder to get. Determine whether some kind of sampling is needed, and then identify possible sources of bias and address them to the extent that is practical and achievable. Again, an example from our PXE registry, we asked 900 questions of 4,000 individuals over the last 17 years, and early on we wanted to determine whether or not the people who stepped forward to answer these questions electronically online were different than the people who did not or could not use the internet. And in our case, blindness is part of the condition, and so that was a very important question. So in the first 600 that answered online, we then looked for 60, so 10% individuals who did not answer and were offline, and asked them the same questions in a telephone interview, and determined, in fact, that their answers were essentially the same spectrum as the questions. The answers were in the same spectrum as those who answered online. Later, we decided we should also ask people who did not want to participate the same questions once we got past them not wanting to participate, because we thought perhaps the non-responders or those who didn't want to answer the questionnaire were exhibiting different phenotype or characteristics of the disease, and again showed that in fact they were not. But very important that we recognize that we do in fact have bias, and that we should try to overcome it if we can. Data elements, its importance in relationship to the primary outcome are one of the more important aspects. assessing data collection's burden, so sometimes it's hard to collect data. For example, if we had decided to call up 600 people versus 60, it would have been much more burdensome, and we couldn't afford it. Then again, standards and common data definitions or validated instruments. Very nice when you can get a validated instrument. So for example, within our questionnaire, we incorporated a quality of life survey that had been validated, and that made that part of our registry questionnaire much easier to deal with. And then pilot testing. It's very important to make sure that you test it. It's quite amazing. Even when we wrote our survey the first time, we had the advantage of having several epidemiologists from CDC work with us. But some of the questions did not test well, and individuals did not understand what they were answering, and that was evident in their answers, and so we could look for ways to make that clearer. There are many kinds of data. There's certainly primary data that's collected for the direct purpose of the registry, and that's everything from self-reported information, which many of our disease registries start out with, but then move on to collecting actual medical records and images and lab results, that sort of thing. And then there's secondary data that's collected for other purposes, and these are the increasing number of electronic medical records and certainly the current paper records, institutional and organizational databases. Administrative and claims data is abundant and is used for many, many things. Death and birth records, census databases, and existing registry databases. In crafting a project, a problem, a solution in a registry must consider the cost, the timeliness, the structure, the availability, and the quality of the data that you'll be receiving. There are some that swear that the only way to get quality data are medical records. There are others that swear that medical records are among the worst and most dirty data because of the way that it is collected on the fly in the clinical visit, and the non-standardization of terms, et cetera, across various institutions and cultures and et cetera. So I think those are very, very important considerations. Ethics, sharing, and data access, I think, is an area that's very much evolving, and I'll do a little pitch here for a workshop that we're going to have all day at Primer in the, I think in the fall it is, at their next annual meeting the day before on biobanks, and we certainly will be looking at some of these questions because we've begun all of us to hear more and more sort of hue and cry for a request for information from lots of people and aggregated data sharing. So what we want to do is to be able to do this in an ethical way, but one that doesn't just clamp down on the research, but instead enables the research, and there's a real balance there. And so certainly the Common Rule, HIPAA, the Health Insurance Portability and Accountability Act, and community rubrics or culture is important. In addition to that, I'm going to also propose that we begin to consider fair information practice principles more heavily than we have in the past. I think we, in the registry and biobank business, tend to think about whether or not somebody has consented, and we place a great deal of burden on that consent, either form or process, and in many cases simply a form. That never was the purpose, essentially, of a consent form or process, to have the entire sort of transaction or relationship between the participant and the entity that's collecting the data be the be-all and end-all. And I think that some of these fair information practice principles are great to be revisited and, in fact, incorporated more meaningful into registries and biobanks because they will allow a better engagement and a more robust engagement that doesn't just depend on the informed consent. And I won't go through all of these, but essentially the principles are that there be notice and awareness, so lots of information for the participant about, you know, where was this information collected and what's it going to be used for and who's going to see it, that sort of stuff. Choice and consent, and I think even this comes from the FTC, they're talking about opt-in and opt-out, and they start to talk about there will be other ways to do this electronically, and we're very partial to granular preference setting, that opt-in and opt-out really don't answer the question for many, many people. They answer it for only a snapshot in time. It's not contextual. It doesn't allow me over the lifespan to change my mind. It doesn't allow me to opt in for some of my information and out for others. it doesn't allow me to make determinations based on a lot of the things that are contextual in my life. Others of our webinars will explore that in greater depth, including the one we just had last week on Registries for All. So access and participation is important, integrity and security, and we could go on and on about that. I welcome you to come to our webinar series on the Presidential Commission's report on privacy and security. That deals with some of these issues, and we're talking both about the managerial as well as the technology fixes for security in that regard. And then enforcement and redress is all very interesting issue because lots of these systems, registries and biobanks, don't have any way to enforce even things like the Common Rule or HIPAA because there isn't somebody looking over them. And so self-regulation is going to be important, private remedies in some cases, and then in the extreme case, government enforcement. Just move on here. Sorry, just a little trouble. So on to operating registries, which I'll only spend a couple of minutes on. Essentially, you're going to want to look at recruitment and management of your participants, and again, that's back to questions like, will you be just collecting around one geographic area, or will it be around one disease, or is it disease people affected by a condition as well as controls or family members, data collection and quality assurance, adverse event collection and management, and data analysis and interpretation are all going to be part of how you operate your registry. And then evaluating registries is another area we'll speak about. So recruitment can occur in many places. It certainly does occur in facilities like hospitals or practices or pharmacies. Providers might in fact be involved. Certainly disease advocacy organizations we've seen. Genetic Alliance's Disease Info Search right now is listing about 75 organizations that have their own registries. There will be a project, another pitch here by the AAAS working with AHRQ to look at registries that disease advocacy organizations are running. Certainly social networks have become another place where recruitment can occur, and in fact will be increasingly important, I believe, and then other places of social and business interaction. So you could recruit for a registry at a church, at a gym, certainly many, many places where people are, and I think if one of our goals are to make registries a palatable experience that's accessible for individuals, we're probably going to want to think about how do we put those where people are. And as we see, for example, Walmart and Safeway start to put clinics and vision centers, et cetera, in their stores, you know, why aren't we also considering the opportunity to perhaps engage in building registries, doing research, clinical research in places where people already are so that it isn't as burdensome or our catchment is not so small. Motivation for participation in any of these scenarios differs, and that's very important to think about how to incentivize that. And then it's important to set goals for recruitment, retention, and follow-up, and they should be explicit, and any deviation should be continuously evaluated for risk of bias. So, for example, if my goal for recruitment is 50% men and 50% women, and I'm getting 75% women, I should not then alter my goal and say it's 75% women so that I'm meeting my goal, but instead determine why is it in fact that I am not attracting men to be part of the registry as well. Retention is important too, and I believe very strongly that it's very much dependent on how engaged the participant feels. We live lives now in which we enroll in hundreds of things in a week because of even simple things like being opted in for mailing lists that we never wanted to be on, or deciding that we're going to try Spotify over Pandora, and then all of a sudden there we are, or Plaxo, which for some reason I can't get out of because I can't get my password ever again. Those things, I think, retain us if they're interesting, if they're engaging, if they meet our needs, and I think the same thing is true of registries. And while that sounds very burdensome to the traditional researcher, it's important, and it's part of what we start to think about. How do we do more of this through social networks, through places that individuals can have their needs met at the same time as participating in something. It's a place that I think disease advocacy groups do an especially good job because they are already trust communities. individuals go to them for support, and then the natural extension to research can happen. Those individuals then usually receive some kind of follow-up and some kind of reporting, even if it's just in a general level, and again, participants feel very engaged if they hear from the researchers themselves, and there's certainly a whole body of literature that shows that. The work of Kelly Edwards, Jane Kay, Amy McGuire, and many others that I shouldn't even start listing, because there are many who are doing good work in this area. Data collection and quality assurance, and again, I'm not going to go through all these in great detail. These slides are posted on our website, and this webinar is recorded. This certainly means things like collecting the data, cleaning it, storing it, that sort of thing. Critical factors in data quality are how do you structure those elements, what's your data dictionary, how did you train your personnel so they don't introduce kinds of either bias or problems with data, and then how do you handle the problems when they arise. And then quality assurance, again, making sure that sources of error or potential lapses in procedures that could affect the quality of the data are in the context of the intended purpose, that making sure that you're taking care of those as you go through the registry creation and operation. And then adverse event detection process and reporting is very important. Collecting those is usually required by the Institutional Review Board if there is oversight over the particular registry. And then sticking to protocol in that regard is important, and obviously following regulatory requirements, particularly if, for example, it's a drug trial registry. Analysis and interpretation, it's important to look at the data in a with a statistical analysis plan of some sort, looking at both primary and secondary objectives. There's all sorts of jokes about how statistics can tell you exactly what you want it to tell you, and it's important that you're clean of any kind of bias in that regard. And then being able to report on the characteristics of the patient population, looking for endpoints and that sort of thing. And then in the interpretation, it's really being able to say clearly who was studied and is it representative of the population that you wanted. And then how were these data collected, edited, and verified? What's the completeness of that outreach, et cetera? And then how were the analysis performed will be important. And then evaluating registries, I think, is something that lots of registries probably don't have the time or budget for, but is very important. And so I'm glad to see efforts like the AHRQ and the AAAS efforts. Quality component analysis, looking at the components that are classified, for example, basic practice and future directions, those sorts of things. So I think, again, what we want to do always is improve these registries so that they are meaningful. Individuals will start to understand the value of them in addition to the scientists who are used to using them. Okay, I'm going to switch now to biobanks in just one moment. So biobanks are repositories, and I'm taking this definition from Gail Henderson's paper characterizing biobank organizations in the U.S., which is a recent paper that came out in January. They're repositories which assemble, store, and manage collections of human specimens and related data. And as I was putting this webinar together, and this is an area that, again, like registries, my knowledge is street knowledge, and I have myself done landscape analysis a couple times on both registries and biobanks in earnest, but not to the degree that Gail has done it. And because her data was so clear and clean, as far as I could tell, I thought it would be good for me to use her work largely as a basis. And in fact, I'm regretful that I did not invite, in fact, her to present this part, and actually should have asked Nancy to present the prior part. But in any case, again, because this is for those of us who are not as familiar with biobanks and registries, I think it's fine for me to proceed in this manner. So she looked at many, many things in her survey, which was really fabulous. One of the things I thought was interesting is the primary reason for the registry to be established. and she looked at those established before 2003 and those established after 2003. And remember, the early 2000s were the beginning of the genomics boom, so we started to see more and more interest in people being put into registries. And so what she found, in fact, was that about 59% of registries before 2003 were created to facilitate research on a particular disease, and 22% for research in general, and then other 19%. And then after 2003, we saw a decrease in the particular disease registries and an increase in the general research registries. And I would imagine that were we to continue to map that out, it will be what we see. There's even large scale calls for more and more of these biobanks that essentially are facilitating research and are perhaps better stated as research platforms rather than a way, in fact, to do research or answer a particular question. The types of specimen in storage are all sorts of things. They are certainly a large number of serum or plasma, and then lots of paraffin-embedded tissue, some whole blood, and so on. You can see this list here, down to smaller amounts of things like pathological body fluids and hair and toenails. So the vast majority of biobanks are probably storing DNA, tissue that's excised during surgeries, and or biopsies, those kinds of things, and then whole blood. So how are these specimens acquired? The acquisition comes directly from individuals donating them in 75% of the cases of these biobanks. Residual specimens account for 57%. That's an interesting statistic as well. I think probably years ago, 10, 20 years ago, it was largely residual specimens, and that we're seeing a surge in individuals donating, and that we will continue to see that, in fact. And then certainly other kinds of things like orphan collections make up a much smaller part of this whole thing. The specimen contributors, individuals with a particular disease make up 76%, patients 76%, so we're seeing pretty much an equal number there of individuals who are interested in a specific disease, and then the kind of a more opportunistic situation where someone is hospitalized or in a clinic, then participants in cohort studies, clinical trials, and then geographic community-based biobanks. Again, I believe that will be an area that we'll see grow more with things like the Vanderbilt Bank, with countries like Iceland or Estonia or the UK. And then type of larger organizations the biobank is part of. So one of the things that Gail discusses in the paper is the fact that a lot of biobanks are related to other entities, and that in fact sometimes it's hard to untangle what this embedding looks like. And so what we're looking at here is that lots of them, 78%, are in academic institutions, hospitals or healthcare organizations, and then it trickles down. One comment I'll make here is that disease or advocacy organizations, only 19 of them that were embedded in a larger organization. Many times those are freestanding and are not part of a larger entity. And then funding, which is a very important thing, and one of the reasons why some biobanks are abandoned or are no longer used. A lot of funding for biobanks apparently comes from the federal government, 36%. Then some come from the larger organization, 30%. And in some cases, that's still federal funding because maybe it is part of some organization that gets federal funding. Fee-for-service only accounts for 11%. Individuals or foundations only 10%. So I think what we're seeing, and also interesting, the CTSAs only 2%. So I think we're seeing that a lot of dependence on the federal government currently. I am not sure that we can depend on the federal government being able to support the numbers of biobanks that probably researchers want to see or that individuals living with disease want to see, and that we're going to need creative ways to, number one, probably bring costs down, and number two, to find other activities that would support the biobank as part of that activity. In our case, the Genetic Alliance Registry and Biobank, which I'll go into a little bit today, in fact, has been able to bring costs down dramatically from 2003 when we founded it, and also to offer services a la carte in a way that don't cost as much. Those services and the bank itself are supported by the disease advocacy organizations that use it, and nonprofits as well. So that's another model that I think will continue to grow. This comes from a paper that I wrote with Liz Horn in 2011 after we did a survey landscape analysis, and essentially found many of the same things. In this case, we're looking at, what do we believe should be standardized in biorepositories, much like we looked at with registries. And I won't go over our registry ones because they're done far more eloquently in the user guide. But biorepositories also need standards, and there are certainly some people who have been quite eloquent on this issue. Caroline Compton, certainly ISBER, the Professional Society of Biobankers, and others have commented on this, that we in fact need to constrain as much as we can how tissue is prepared, how it's characterized, how it's even used and shipped and all that sort of stuff. And so as much as possible, that should be well done. In Genetic Alliance Biobank and Registry example, we have increasingly moved to vendors that are more and more sophisticated in this regard, both because the technology has changed over time, as well as our ability to engage the best vendors has improved. So moving from, for example, working with a friendly hospital who would help us make sure we had a good system with a standard backup in terms of power and things like that, to now being in a full-blown facility that is meeting all of the current guidelines and regulations. We built a criteria and scoring scale used to assess vendors. Our purpose in this paper, this is June 2010, was in fact to help disease advocacy organizations make decisions about where they should be storing or who they should be working with, and gave a scale whereby those entities, those vendors, could be scored. Some of this is out of date now, in fact, because I think we have more standards that are available to us as the HITECH Act and others roll out, meaningful use rolls out, but some of it is still quite timely and useful. So just I'll give a couple of slides on the Genetic Alliance Registry and BioBank. This is the advocacy-owned and managed data repository and sample repository, storing about 30,000 samples and 20,000 clinical records. You can find it at biobank.org. And again, it's for any nonprofit or disease advocacy organization to manage their own collection. It was established in 2003, and it's basically to accelerate drug development and treatments, characterization of the disease, et cetera. And we have a whole host of tools built into the bank. You're looking at a screen that allows individuals to set their privacy settings for their biological samples or their data, and allows them to make that fairly granular as to who sees it and as to what kind of data is shared. It goes even much more granular if individuals are interested. And if you're interested in this particularly, you can look at the webinar we did a week or so ago called Registries for All. The nice thing about Registries for All system that's overlaying the Genetic Alliance Registry and BioBank is that, in fact, it allows individuals to set their own privacy preferences and to work on the kinds of questionnaires, registries that we've been talking about, but do it in a gamified way. And that is to be able to see how they compare with someone else immediately. And the kinds of things that you're seeing on the screen right now are our teaser questions. They are not our registry questions, but we do get individuals through this sort of kind of fun process and then have them register their privacy, data sharing, and their data access preferences as individuals, and then ask them the kinds of questions you would normally would in a self-reported registry, as well as opportunities to upload various kinds of information. Later this year, we'll be connecting also to electronic medical records, and this will allow individuals then to import more of their information and to control who sees it and when they see it. I think one interesting thing here, again, to the point that we've been making about participants being engaged and feeling like they're in a trust kind of environment, we find people using this site stay on this page for a very long time compared to most people in most web interactive situations. And so, for example, average times are somewhere around 9, 10, 11 minutes for an individual on this site because it is engaging, it's fun, it's interesting. I can come back in and see how many questions I've answered. I can come back in and see how I compare to others and how that might change over time. I can constrain it and see how I compare to others with the condition that I have, and so on. And so I think this offers a way to think about engaging people in a registry platform, in a biobank platform that is much more engaging than we normally see. The website biobank.org offers a lot of information, and some of the things that I've talked about today are easily available there because the website is meant to be for the neophyte, for the person who needs new information about biobanks. And one of the real great features of it is this toolbox that we've built, a toolkit, essentially taking the disease group or the nonprofit, because we're in fact working with First Nation groups and Native American groups, African American groups. You know, how do I start? How do I make it a reality? Am I ready to do it? And you can see here color-coded our training videos and webinars and all sorts of things. This webinar will be added, for example, to this toolbox. What else do I need to know? How do I stay current? And these click out to lots and lots of the resources that are on the web that are fabulous and done by individuals and organizations from the government, from research organizations, et cetera, that are very, very valuable. This is becoming a very rich area, and there's certainly a lot of information. So I think to close, we want to look at the lessons that we've learned in our kind of building it from the ground up as citizen scientists. The sorts of things that I think now, looking back 10 years since we've started this cross-disease platform and 17 years since I've started the PXE endeavor, is that we should not be duplicating efforts. That their registries and biobanks are expensive and they're administratively burdensome. And so the more we can level the playing field, give individuals and organizations the tools they need to participate without it being burdensome, the better. We need to develop partnerships that will allow us to share data and resources, ensure that the registry or biobank is sustainable over time. There's been a number of groups that have started out with one and then not been able to keep it to sustain it, and that isn't a good thing either in terms of their own community or in terms of the science. Common data elements, control vocabulary, standards for interoperability, all that's really important and becomes increasingly so as we do move more towards standards overall. Follow best practices, again, ISBER and Primer and quite a number of these organizations, and all of these acronyms and URLs will be on our website. They provide best practices that are evolving and are very useful. Engage your participants, keep them, attract new ones. That's going to be very important, and it's something that I think these organizations can do really well. More and more hospitals are and clinics are creating communities, and that's fabulous, so let's build on those. Proper planning prevents poor performance, for some alliteration. That has been proven to be very, very true for us. We've iterated on our bank a number of times, and not only the structure for everyone, but even interior and internal elements. Stewardship's very important. I think we're going to see a lot about that, about people mattering, and about governance in general. We've got to find ways to make governance dynamic, culturally appropriate, and responsive, and particularly around communities that have a more difficult time participating in these because either they don't live in academic medical center areas or they live in communities that have not generally participated or have participated and not received benefit from the participation themselves. So I think right from the start, whomever you are serving has got to be part of the planning and of the design and of the ongoing follow-up. I want to mention just our biotrust ethics team. We believe that all of the work that we do at Genetic Alliance in translational science should be governed, and governed by people who know the ins and outs of both the experience of working with these banks as well as with participants generally. And that group is chaired by Kelly Edwards at the University of Washington, and you can see the other individuals here from universities, from startup companies, from disease advocacy organizations, and so on. And then my final slide here, just a couple of URLs. Again, these will be available to you so that you can look yourself, but the Registries for Reporting Patient Outcomes guide is excellent. The Henderson paper on biobanks is freely available on the internet, open access. URL there for Genetic Alliance Registry and BioBank, and the Registries for all URLs. We welcome you to play with any of those. And we always welcome comments because we are ever trying to improve these. So that is it for my formal presentation. And so I'm going to take questions now. And I'm just going to go down a list of questions that we've received during the time that I've been speaking. And the first one was, do all disease groups need a registry or biobank? And that's a great question. I would like to say no, and that there will be cross-disease and large institutional registries and biobanks that disease groups could use, and in part because I don't think we should be siloing diseases. I think as we have more and more a systems biology approach, phenotype approaches, comorbidity approaches, we're going to need cross-disease biobanks and registries. And so I would say no from the perspective of the group themselves establishing one. I would say yes from the point of view that having a well-characterized cohort that's characterized for a good amount of time longitudinally over time that allows for the validation of biomarkers during that time well before you even have an idea about a treatment for a disease is useful. And that I've heard over and over from industry, from academia, that if in fact those cohorts existed and there were well-validated biomarkers, then research would certainly go much more quickly. And so I believe it's never too early to start to characterize the population with whom you work, again, even well before you see an opportunity. And then a related question, so how much time, energy, or staff does it take to manage a registry or biobank? We thought a lot about that question here. Now that answer will come in different ways for different groups. If we're talking about hospitals or countries, a lot of time, a lot of energy, a lot of staff go into those. It's not trivial at all. If we're talking about disease groups, we've been trying as much as we can to figure out a cooperative model that would reduce the burden on the disease group staff, would also take out some of the issues around the funding, et cetera. And we have a webinar, I will get somebody here on my staff to tell me the date, that's coming up that is a very small group of disease groups that are really seriously considering registries and biobanks. And in fact, we'll put on the screen for you the upcoming series, and you can see that on June 13th at noon, we'll be having a discussion of that right down to the nitty-gritty of how much time, energy, and staff. I can answer that from the point of view, of course, of my disease group. And we have a person, Abby Moore, who works 50% time on our biobank and registry. And then costs annually for us, this past year we're somewhere, and of course this depends a lot on volume, how many samples are you taking in, how much DNA extraction are you doing, that sort of thing. So it's not an easy question to answer. But costs for us last year were somewhere around $18,000. Those will be moderately lower this year because Genetic Alliance Registry and Biobank, of which PXE is a part, is lowering all of our costs in terms of biobank activity, membership fees, that sort of stuff, and storage fees. So we're going to see a decrease in those costs as well. And then energy, I find it one of the most important things we do. We have, from our registry and biobank, almost 50 papers in the last 17 years have been written based on that. We have our first clinical trial for a treatment based on our registry and biobank's work, and so it's been very, very important. Question, how do you formulate the questions that we should ask in our registry? And I'm going to take this from the disease advocacy or disease-specific context because there's lots of ways to answer that question. And I would say the best thing to do would be to assemble a group of experts and make sure you have people who are expert in epidemiology, natural history, in registry work, because how you formulate a question is really important, not just what I'm trying to get at, but how I'm going to ask the question. And I remember early on, for example, the question we formulated around cigarette smoking turned out to be very poorly worded. And when CDC began to help us look at how we were asking questions, they pointed out there were more standard ways to ask those questions. And so some things are standard. Some things are validated questions. Some ways of questioning are validated, and others are not. And so I think you'd want to make sure that you gathered a group of experts, that you took the time you needed to plan. In our case for PXE, we took 1 year of meeting every week to decide what the 900 questions we were going to ask would be. And those questions were, by the end, fairly well formulated. And then in the testing phase, as I said, we came up with some that we really needed to modify. Next question is, Registries for All, a tool disease groups can use to build a registry. What about Reg for All and biobanks? Yes, absolutely. So we have designed Reg for All with a back end that we'll actually show during some of our webinars that are upcoming, that will allow individuals to create their own questions and put those out for the community to see. And by community, I mean even beyond their own specific community, since Registries for All is getting traffic from all over the world from many quadrants. And then how about the hookup between Registries for All and biobanks? That's something that we're working on right now. We have expanded the Genetic Alliance biobank part to include individuals now. And so individuals are donating DNA, tissue samples, especially from surgeries, to the bank, and setting privacy and data sharing and data access settings for those samples. And so that hookup is in the process of being made more formal, but right now that's possible. The question from someone, we are looking to establish a registry for a specific disease. Are we better to establish one for our specific disease or engage in a general available registry? So I'm going to give you my opinion on that, because I don't think there's a consensus around that question yet. My opinion is that it will be good to shop the platforms that claim to be cross-disease for the reasons that I stated before, and those are that I think we will be starting to see more work being done in a kind of systems biology or looking at phenotype kind of way, and that some of the solutions for diseases won't be cures. They may not even be treatment of the primary manifestations of the disease, but in fact may be important for some secondary or downstream manifestations, and those can be shared across conditions. And things like fatigue, joint pain, breathlessness, and certainly lots and lots of quality of life things, on and on and on, mental health conditions, et cetera, will find that they can share at least some understanding of disease and pathways of disease. I think it will be important that within the general registry, everything is standards-based and it's interoperable with all other registries. And I think also that you'll want to be able to pull out just that disease's information. So while I am saying I believe a general platform, which is why I've put my energy into one, a general platform is a good idea. I do also believe that you should be able to segregate out the data in whatever way you wish. So for example, by phenotype, or in fact by the traditional disease silo that you come from, and I think that's completely fine. Do registries and biobanks need IRB approval? So this is also a very interesting question. Many people will say yes. We've also had some very robust dialogue with quite a number of people, including our own biotrust ethics team, around what constitutes a research platform that is not an actual study and what is an actual study. IRBs look at reviewing for an institution what is ethical about the treatment of participants in a study. And so if the biobank or the registry is a platform and not a study itself, then in fact it has been determined by some experts that it does not need institutional review board. The other kind of tricky thing here is when you get to systems like Registries for All, where individuals are making decisions about data sharing, data access, then what would the institutional review board be reviewing? In fact, you would need an individual review board. And instead we thought, in our case at least, that the ethics team would be a very good governance body for that, in the sense that they can begin to start to lay down the rubrics for how this should be governed. And certainly when we get into subpopulations of specific individuals, for example, we're doing a liver pilot, we've engaged individuals with liver disease to be the governors of that part of the registry. And that, by the way, is a very brief answer for a very complicated question, and one that could be debated a lot, and one that we will bring into our workshop in the fall with Primer. Can you speak to the problem that some biobanks have of not having a lot of requests to use their samples? So this is an interesting problem because earlier I said, yes, we need to have registries and biobanks. I think it's also incumbent upon, in some cases, the builders of these biobanks and registries to actually find ways to make those samples available easily and to be interesting. And by that I mean you may be building a registry for the most esoteric, very, very rare, ultra-rare disease and finding no one's interested. Well, the problem is not the samples or the data. The problem is finding who would be interested in this information and working on this data and the samples. And I think what one wants to do is to start to think about what is this related to, what other diseases may share a part of the phenotype, what other laboratories are working on something in the pathway where they may have a postdoc or someone else that could be interested. How can I incentivize interest in my condition? And I don't advocate for all of us arguing and fighting with each other with 7,000 genetic diseases, but I do advocate for us figuring out what are synergies, where can I build on what someone else has done, where would this be a value add for a laboratory that is looking for meaningful projects, that sort of thing. And that I think once one begins to think that way, there is no shortage of requests to use samples. The PXE bank that is, again, 17 years old, has received requests from about 50 labs around the world, and that's fairly good for a disease that's 1 in 100,000 people. Then how much funding is needed to start a bank? Somewhat related to the time and energy question. Again, I think what you want to do is examine carefully the options, look at how much those options would cost, be very realistic about what the vendor of those options says is required. And then I think the paper that we wrote, I think the one in 2010 that I wrote with Liz Horn, is useful for sort of scoring the attributes of banks to see, you know, what might I need to start up, and then especially in terms of cost, what would be important. I think we have come to the end of the questions. If anybody else has another question, we have about 2 minutes, and we can take another one in the little box. But I think we are good. This certainly doesn't end the conversation. It only begins it. I wish we could have opened the lines because, again, we have a lot of experts on the line that are far more proficient than I at this topic. But I hope this gave everybody a good introduction to the concept. You can see the screen that's up now on your desktop or laptop shows you the next biobank and registry webinars that we'll be having. So the next one is May 29th. That is at noon, and it is Registries for All and disease advocacy organizations. And so we'll be essentially showing disease advocacy organizations what they can do with Registries for All to create registries for themselves. We actually have 2 options, that and Genetic Lines Registry and Biobank, and so later in the series we'll be talking more specifically about the biobank and registry option that's a combined one. And then following that, there is the by invitation webinar that I spoke of, and again, that's not so much that we're trying to exclude anyone. We just want to make sure that we get a small number of individuals who really are serious about creating biobanks and registries, and especially about Registries for All. And then further into the series, into the summer, we'll be looking at specific stakeholders like researchers, individuals, and so on, including one, and if we just scroll up a little bit, on our partnership with the Inspire community. And while I didn't mention this, but clearly Inspire is not a registry, it does hold a lot of data and a lot of interesting information that individuals are sharing, and we are in the process of developing some tools that will do some semantic web mining in open spaces and allow associations between symptoms and treatments, et cetera, to happen. We have a project that's begun that was discovered in this manner, where a drug used for one disease apparently is working in another, and we're in a phase 2 clinical trial with that drug by mining blogs and communities like Inspire. And so we welcome your feedback, your recommendations about what we should be doing going forward. You will be receiving a survey after this webinar, and you can put in that whatever you think is important, and also any comments on how we might make this series better, as well as these individual webinars better. So I want to thank you all for attending and wish you all a good day. Thank you.